Okay, Doctor. All right, Doc, looks like Dr. Atterbury's logging on right now. Dr. Cleary did let us know that he was not going to be able to make it today. And then Dr. Atterbury?
Yeah, I'm here.
Okay, thank you. And then Yakima Health District staff, Andre Fresco.
Here, good morning.
Myself, Ryan Iback, Chase Porter.
We can't hear you, Chase. Your audio is not working.
Okay. So Chase is here. Melissa Sixberry.
Here.
Lillian Bravo.
Here.
John McGee.
Good morning.
Nathan Johnson.
Here.
Dr. Bard.
Here.
Jocelyn Castillo.
Here.
Victoria Reyes.
Here.
James Elliott.
Morning.
Thank you. Now we'll move on to the review of submitted public written comments. Mr. Iwalk. Any?
There were no submitted comments.
All right. Anybody present online who would like to make comments? I don't see any I don't see the whole thing either, though. So we'll move forward then to item 4, which is consent agenda. A motion to approve all of the items listed with an asterisk are considered routine by the health board and will be enacted by one motion. There will be no separate discussion of these items unless a board member requests, in which the item will be removed from the consent agenda and considered in its normal sequence on the agenda. I assume everybody has a copy for the agenda in front of them. I will ask for a motion.
Move to approve the consent agenda as presented.
Is there a second?
I will second that.
It's been moved and seconded. Any further discussion? Hearing none. All those in favor?
Aye.
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 Any opposed? Hearing none, the motion passes. We'll move on now to the Health District Spotlight presented by Lillian Bravo.
Thank you. Good morning, everyone. So today we'll be talking about the work that we've done related to opioid overdose awareness as a team. Over the last few months, we've been connecting with partners to see what other work is taking place, collecting data to analyze some of these trends to share with you all, and developing materials to raise awareness in the community on this very important issue. So today we'll include a summary of this work, and I welcome your questions at any time during or after the presentation. So if we can go to slide 3. We'll begin with level setting on a few key terms that we'll be referring to throughout the presentation. The first is opioid, which is a catch-all term that refers to drugs that are derived either naturally, synthetically, or semi-synthetically from opium, which is derived from the poppy plant. These drugs are most often used to reduce pain, and the most commonly used opioids are prescription opioids, fentanyl, and heroin. So fentanyl, in turn, is a type of synthetic opioid. It is highly potent, and it can also be prescribed to treat severe pain among those who are recovering from surgery or going through cancer treatments. But it is also manufactured and distributed illegally. This type of fentanyl would be considered non-pharmaceutical and is typically the type of fentanyl that is associated with overdose deaths. Also, another term is naloxone, which is a medication that can reverse overdoses due to opioids, and it can be administered into the muscle or given as a nasal spray. So having level set, we'll now start with reviewing some of the national trends. So these charts show the number of overdose deaths among all ages from 1999 to 2020 from any type of drug. On the left-hand side, you see the chart that has a line in yellow, which shows deaths among males, and then orange, which is deaths among females. So as you can see overall, since 1999, drug overdose deaths have increased significantly. They've actually more than quadrupled in that time frame. When you look at figure 1, you can see that deaths have consistently been higher among men than women. And overall, it's widely recognized that opioids are driving this increase in overdose deaths, as is shown in the chart in the top right corner. This chart also describes the 3 waves of the opioid overdose epidemic. That first wave, which is started in the 1990s, is a result of an increase in prescribing of opioids to treat pain. And there was a second wave or increase in overdose, which involved heroin right around 2020. Now, more recently, you can see there's been an even larger increase in deaths due to the emergence of more deadly synthetic opioids such as fentanyl. So unfortunately, drug overdose deaths are now the leading cause of unintentional injury in the US, which has surpassed motor vehicle accidents. It is important to note that the CDC reports that since 1990, even as the amount of opioids prescribed and sold for pain has increased, the amount of pain that Americans report has not similarly changed. In the next slide, we'll look at Washington State. So as you can see on the right-hand side, there's a similar pattern in Washington State as across the country, with exponential increases in the number of opioid-related deaths in the last 2 decades. In this line chart, we're viewing rates per 100,000, which is charted across time, again, from 2000 to 2020. The solid purple line at the top represents overdoses from any drug, and the dotted yellow line shows the sharp increase in deaths due to synthetic opioids more recently. The map on the right-hand side is also showing rates per 100,000 of deaths involving residents during 2018 to 2020 specifically. What this shows is the darker shade of red. The darker the shade of red, the higher the rate of deaths due to opioid. And what this map is intending to represent is that even though deaths have occurred throughout the state, the geographic distribution of these deaths have not been the same. So some of the highest death rates and largest increases in deaths are seen in more rural counties, including Yakima County.
Lillian, what is our rate as opposed to the state's rate of 4.58?
I don't have the exact number, but what we can see is that on the top, it shows that the state average is 12.58 per 100,000, and that it's a lighter shade of red. So we are slightly higher given what the chart is showing visibly, but I'm happy to pull those specific numbers and send them out.
I just got the information yesterday. I'll pull it up in the next minute or so.
All right, thank you.
And Lillian, another question for you. You mentioned that they're more common amongst rural, but looking at that map, it looks like they're more common in densely populated areas, at least for Washington State. Is that correct?
That is true in some of the areas, but if we want to look into the specifics, I'm happy to pull the actual numbers, because unfortunately what we're seeing is that red is taking place across the entire state. So I can see where it can get the shades are blending in together. So I'm happy to provide a follow-up with more specific rates so we can have a better comparison. Thank you for the questions. And on the next slide, we'll take an even closer look now at Yakima County. And what we're seeing again is a similar trend that's taking place nationally and across the state. Again, similarly, opioids have been implicated in the majority of those deaths. This chart shows that in 2018, fentanyl accounted for about 38% of drug-related deaths. And by 2021, it accounted for 56% of overdose deaths in Yakima County. Preliminary data from 2022, which thank you to our coroner for providing that to us, also shows a similar trend. It's not here on the slide because it is not complete data, but we are seeing that, again, it's following similar trends. And in fact, all of the drug overdose deaths in 2022 have been involved fentanyl. In slide 7, again, we're looking at Yakima County specific information. And now we're looking specifically at demographic data. The different shades of blue represent different years, again, 2019, 2020, and 2021. On the chart on the left, we can also see that overdose deaths have increased among all racial groups. However, sharper increases were observed among American Indian, Alaska Natives, and Hispanics. When we look at overdose deaths by age group, which is on the right, the number of deaths again increased among all age groups, but we saw the sharp, but in 2021, we actually saw a decrease in deaths amongst all age groups, except the 30 to 49, which experienced an increase. So now we'll move on to slide 8, which again, despite the discouraging trends, it's important to note that overdose deaths are preventable. And so what we're looking at here is just a description of different prevention strategies. So of course, the first step towards preventing drug overdose is preventing drug use from happening in the first place. This would be considered primary prevention. Some examples of this would include education and outreach, providing more information on the importance of limiting opioid prescriptions, as well as limiting the access to prescription drugs by disposing of them properly. However, it's important to also reduce injury and death among those who are already using drugs, which would include different strategies referred to as harm reduction and evidence-based treatment. So again, sometimes treatment may not be enough, and a person may also need more long-term support to stay safe and healthy. Moving on to what's happening locally, I'm very happy to report back to say that locally, we as a community are already doing some form of each of those strategies. In Yakima County, there are several programs and services in place that are helping to address drug misuse and overdose in the community. I'm struggling with that word, all these S's. So speaking to primary prevention, there are groups throughout Yakima County that are known as Community Prevention and Wellness Programs, or CWPIs. They include community prevention and wellness initiatives through community-based coalitions. So in Yakima, there's several in place already through the Educational Service District 105, here in Yakima, and also at the Highland School District, Sunnyside, Wapato, and White Swan. These groups are dedicated to working with students and parents to educate them on strategies to prevent the use of drugs among youth. These groups are actually funded through the state agency Division of Behavioral Health and Recovery, and they often hold community-based events. I know over the last few months, we've actually seen several of our commissioners attend those meetings, so thank you. Mayor, Councilwoman Byers, did you have a question?
Yes, thank you. I wanted to go back a slide. I didn't get my hand up soon enough. What is the Good Samaritan Law?
Let's see. So Melissa, do you have?
So the Good Samaritan Law is, it allows somebody to administer naloxone without having any legal liability on any complications that would arise from that, and also being able to assist in somebody who's having an overdose.
Thank you. Appreciate that.
I actually have a question, if it's okay, since it's related to this screen. And maybe we can go into depth, but I'd really like to know what the effectiveness is of fentanyl testing strips and syringe exchange services for actually successfully getting people off and away from being someone who's a habitual drug user. Can we maybe look into that? I know that's a deeper question, but I question those methods as being methods that are successful in getting people actually off the drugs.
Commissioner McKinney, that's a little more involved question. Do you mind if we finish this presentation and then come back to that question?
Absolutely, absolutely.
Thank you so much.
Thank you. All right, so we covered the CWPIs, and then moving on to safe medication returns. So again, these safe medication return boxes are intended to prevent any potential access to opioids from potential family members or others who were not originally prescribed those opioids. And so this is a way to, again, safely dispose of those opioids. So several years ago, as Commissioner Anderson will likely remember, the Yakima Health District assisted in procuring several of these medication drop-off locations throughout Yakima County. So safe medication return boxes are readily available throughout our community at police and sheriff's departments and several pharmacies, including hospitals and community health centers. As of a few years ago, Washington State passed new legislation which requires the pharmaceutical companies to maintain these boxes moving forward. And local health departments are expected to work with these companies to advise them on how to best provide access to medication disposal, whether it be increasing the amount of boxes in our community, also making the public aware of different mail-back options if for some reason a community is extremely rural and aren't able to readily access these boxes, or both. So that's what's happening with safe medication return. And then also at the Yakima Health District, that is listed, we have several different programs, one of which is the Syringe Exchange program, the National Disparities Initiative, and then also talking a little bit more about the awareness campaign. So these would be considered harm reduction services, as well as partnering to provide evidence-based treatment when referencing the different strategies that were mentioned previously. So moving on, we will review the recent awareness campaign that we launched in early June with information that we compiled in May. So the overall goals of this campaign were to inform the community about the risks associated with opioid use, increasing access to opioid prevention information, and then again, increasing awareness and education about the benefits of naloxone, and really to normalize its use and make sure that people know about things such as that Good Samaritan Law and where to obtain naloxone. So we started the campaign by sending out a media release to share information about the increase in overdose deaths that have been observed locally since 2020. We shared the statistics and more information as well as steps to prevent overdose. We actually partnered with the coroner and sheriff, the sheriff and the police department to put this news release together. And Commissioner McKinney, I see you have a question.
Yeah, and maybe we can touch on this, but I'm really concerned about that last slide where it says normalize use. So I would really like for us to expand on what that means. So that can be something for the discussion as well.
Yeah, and I can briefly touch on that in terms of the really discussing that overdose can happen to anyone, whether it's intentional or unintentional. Some of the comments that you made previously, Commissioner McKinney, about potential younger individuals, wanting potentially being exposed to it. And so it's really, that's what we're referring to, is making sure that people have that readily available in case an accident happens, and that it can happen to anyone.
Sure. I'm just wondering if there's a better term than normalize, because normalize to me means we're accepting this and promoting this as part of our daily lives. And I think that word is inappropriate, but we can discuss that as a board.
Sure. Yeah. Welcome people's perspectives on that. And with the, so that covers the media release. Following the media release, we put together a provider alert that was sent to all of our healthcare providers. Again, we wanted to make sure that providers were aware of the current situation in terms of the increase in overdoses, and then also making sure that people were aware about this campaign in case there was an increase in community members wanting naloxone, that they were prepared for that as well. Healthcare providers play an important role in educating patients about prescribed opioids, about the potential risks of opioid misuse, and also in sharing information about naloxone. And then on the next slide, as with most campaigns, we've also utilized social media to increase knowledge and awareness of opioids. And overall, the campaign has been received well by the community, and it's actually received more engagement than other work that's been shared on our social media recently. This information was also picked up by several different news outlets. And in the future, we plan to expand on this campaign by also launching a webpage on overdose prevention so that we can continue to promote this throughout the summer. And to the next slide, now that we have worked to increase awareness on the issue and on naloxone, we want to make sure that we work on increasing access to naloxone in Yakima County. So as referenced earlier, in 2019, the Washington State Health Officer signed a statewide standing order for naloxone, which allows any person or organization to get naloxone from a pharmacy. So while naloxone access is increasing statewide, there are some barriers that are still in place for young adults and individuals without health insurance. So we want to make sure that we continue to work on making this readily available. And there are opportunities to increase public distribution through community-based organizations, which we'll explore in the future. And then in the next slide, just really quickly, there is a COVID-19 Health Disparities Initiative that allows us to be another local strategy to connect people to naloxone, and also, again, another strategy to prevent overdose deaths. So in the interest of time, I will move through to the last slide, which is how this relates to our strategic goals. So again, though drug overdose prevention is not a mandated service, it still does involve activities such as the Syringe Exchange and linking to medical resources. So that is, again, combating communicable diseases, which is, again, the mandated service. And in the next goal, our current awareness campaign and work related to this is helping us develop a network of community partners and improving the public health overall. So with that, I will conclude, and I'm happy to take any questions now or follow up at a later time if needed.
I think if Commissioner McKinney has 2 or 3 questions, I think before we move on, if we can answer those, that would be good.
Yes, I'm happy to start. If I understand, Commissioner McKinney, one of your questions had to do with the idea of how that relates to harm reduction. And I wanted to share that we've had a harm reduction program that certainly preceded me coming on as executive director. It's been here for decades. One of the things that we didn't have, I think, was a commitment to helping people come off of drugs. So when we talk about harm reduction, there's really two pieces to it. One is the idea that drug use has the potential to spread communicable diseases very dramatically, HIV and certainly others. So one of the issues is that we're trying to avoid the types of epidemics that happen in other communities when you don't have harm reduction programs. So really, from a spreading of communicable disease, our goal is to reduce that. And that's one of the uses for having clean needles. But the issue that you pointed out appropriately, I think, is how do we actually help people transition off of drug use? And that's something that we've really put a great deal of time into. One of the things that we really committed to was having a relationship with Comprehensive. And so we were part of what's called a hub and spoke model. And we really benchmarked that, which was to use our position as a mobile platform to reach the drug seeking community, to allow them to have staff who are available to help people receive services. That's a very big goal because we want people to exit drug use. And so that's important that we were part of that. I'm happy for Lillian or Melissa to share more if you'd like about the hub and spoke model. But the goal was to help with transitional services out of that. We've also had to slow down on plans, but Commissioner Anderson appropriately talked about wanting to encourage more transitional services out of drug use that we want to be part of with the city of Yakima, and that's having a day shelter that would allow people to have more access. So we're really trying to create a partnership model that gets people off of drugs, and that's part of our plan.
Yeah, so I'm really, thank you for that, Andre, and I'm really interested in the data. So how many people have needle exchange, the syringe, exchange program successfully helped transition off? How do you follow these people? Are you tracking them to, if we have people who are, I'm sorry, but sometimes compassion can be enabling. And, how are we encouraging people if this is something that I like the idea of Comprehensive being there, but, is it the appropriate place then for them to get it from the health district? Maybe they need to go to Comprehensive or a place where in order for them to exchange needles, they need to be an active participant in a program that is getting them off drugs.
I understand your point. We're trying to simply encourage more options for outlets for people. They know that Comprehensive exists. I will share with you candidly that the idea of an exchange where you have to be in recovery in order to receive services isn't going to work. I think that would be a failed model, unfortunately, because people are committed to drug use. So our goal at the health district is twofold. One is, again, to reduce the spread of communicable diseases because they would be rampant in a community like Yakima. I mean, we are doing a tremendous business, if you will, in providing clean needles because we want to make certain that people are safe. The other is that you mentioned fentanyl test strips. The reality is that we don't want people to have unintended overdoses, and we certainly don't want to contribute to the number of people who will die. So the reason that we distribute fentanyl test strips is to ensure that people don't die. These are strategies that are about making certain that people live and certainly don't infect others in the community. And I will share.
I would just say, sorry, your comment just struck me. Ensuring that people live. I don't know, being drug addicted in that way, you could call it living. And what you just said, I think, is unfortunately what we all know. The reality is what you said is that people who are coming to use these needle exchanges are quite aware of the programs that are available and that they are seeking not to. So we are enabling their drug use. And unfortunately, my fear, because what Lillian has touched on is that the more people who are enabled to continue use, they come in contact with youth. They expose youth to these terrible habits. And that is how we see an influx in familial drug use. So by enabling a certain set of population to continue this and to support that habit only exposes other people to the same danger. And I see that Councilwoman Byers has her hand raised.
Yes, thank you. I have two questions, and one is, in the syringe exchange program, is it 1-for-1? How does that work? The reason I'm asking is because I know that in cleaning up so many of the campsites left by those experiencing homelessness, there are always multiple tons of used syringes laying on the ground.
Yeah, I'm happy to
So-
answer that. And did you have another question, Councilmember Byers?
Yes, I do. I'm asking about the naloxone. Is there a record of not only people who receive it, but how often they receive it? Do we have a lot of repeat offenders on that?
Well, yes, I'd like to also mention to the board that I'd like us to have a spotlight that's more involved in the issue of our harm reduction program. I think that would be helpful. There really is, it's a layered issue, and I understand that it's not socially palatable for many. So I think that I'd like to hold off on some of the more involved conversations, because I think that we need to have a more explicit discussion about the history of the program and how we do things. I'm happy to answer some questions, but I see that Ryan had his hand up, so I'm happy to.
Yeah, I just wanted to mention that harm reduction is scheduled to be our spotlight for next month. We may answer a lot of questions.
All right, good. Good
No,
time.
but I don't want to leave those unanswered. Your first question was about one-for-one, and I'm happy to have Dr. Barb or Melissa jump in, but we do a one-for-one specifically for one reason. There are other jurisdictions around the country and nationally, really, where people just hand out clean needles. We are committed to making certain that we receive dirty needles, because this really is harm reduction in its truest sense, which is to avoid the spread of disease. But I also want to share with you that I'm committed to the idea that we don't have children learning about intravenous drug use in parks. I don't want police officers who frisk someone to be stuck. I don't want municipal workers who pick up garbage to be stuck. I don't, as you mentioned, Councilmember Byers, cleanups where people can be stuck because people have left refuse. So we're committed to a full service model, which is about making sure that it has value. You also asked, are you comfortable, Councilmember Byers, waiting on some of this for our next?
Yes, I am. I am. Thank
And
you.
I see Dr. Barb's hands up as well.
Dr. Bard?
Yeah, I just wanted to kind of point out that these strategies are parallel. They're not necessarily linear. So if we start at the one end with an active user, we have multiple routes of keeping them safe and alive so they can actually make it to treatment. And if you look statewide, the available treatment slots are actually much less than the people who are available to use them. So we need work on the back end to make that whole parallel effort be successful.
Thank you. Commissioner McKinney, and then Councilwoman Duval.
I would be happy to have Councilwoman Duval go, because mine is just a follow-up to the normalized question. So Councilwoman Duval, if you would like to go.
You're on mute. There you go.
Thank you. So my question more was about the safe medication return. Are there opportunities to for cities having events to have a safe medication return events? I know that this weekend Toppenish is having a wonderful 4th of July celebrations, or maybe we could partner with the hospital to encourage people to return their medications if they're not using them. How and who would we reach out to make that happen?
Yes, absolutely. And there's actually 2 separate dates throughout the year where they'll do national take back days. And so typically it'll be the police department and maybe a city official that'll take those on. So those are nationally recognized ones, but there's always opportunities to host events outside of that. So I'm happy to follow up to connect, because now that these there's a third-party company that's responsible for maintaining these boxes moving forward, the process is going to be a little bit different. So this will be the first time that we look into that. So I'm happy to look into that and to see how we can make that happen.
Councilmember Duval. Oh, I'm sorry.
Let me just suggest to Councilwoman Duval that Crime Stoppers in the Yakima Valley does 2 events a year where they do both shredding and medication take back, and that's pretty well advertised. They may be willing to come out to another community other than Yakima itself. And also I know that Safe Yakima Valley has done that on occasion as well. Those would be 2 places you might contact.
Yeah, I would like to see them more in the lower valley and getting them in different places that are more rural.
Thank you.
Yes, and actually, Councilmember Luau, we were on that track until the state actually changed their direction and made as Lillian pointed out, that they put the drug companies responsible for that. But we're happy to support that. There's two pieces to this that I think are necessary to share. One is that obviously drugs are monetized. So having a police relationship or a law enforcement presence is necessary to ensure the actual discarded drugs are then destroyed. And the other is that those medication take-back boxes have to be in a place where you have pharmaceutical oversight, or what we often refer to as a formulary. So it can't just be placed anywhere. But I think that coming up with a partnership model where it's more available, I think is a great idea. So thank you.
Okay.
Thank you. Commissioner McKinney, you had a follow-up question.
Yeah, thank you. So this was just on the slide, and I don't know if this was maybe Lillian, your choice of wording, or the health district's locally choice of wording, or if this is a statewide campaign, but I really would like to see us use a different term when we're talking about raising awareness for Narcan. I think normalizing use to me means you're actually having an aim of making an everyday part of life that everyone accepts as a normal condition going forward. And I just don't think that we want to in any way be sending a message that this is something that we want to normalize in a way that people just say, well, I'm always going to need to have the idea that I'm going to encounter someone with a drug overdose, or that someone is going to always be near me to administer this to me and give a false sense of security to anyone who's going to attempt to use these really harmful life-threatening drugs. So I just feel like there's a different way to use some terminology that we can show that we're taking this very seriously. We want to raise awareness about this product, but that normalizing it is not the goal.
Well, perhaps, Commissioner, you could maybe help Lillian derive some of that language and submit it to her.
And I'm open to the art of communication and having different words, but I have to say I am a little confused. I know that this board specifically has mentioned their concern that naloxone was not available, that naloxone was not aware of its purpose and intention. So our goal, I thought, was actually to normalize the availability and education and use of it to ensure that people did have it. We talked about the idea that people should be aware of its benefits, that it is something that can be received for free, that people would be encouraged to have it on hand, and that we don't ever want an unintended overdose or death. I mean, the reality in our community around the state, but certainly in our community, is that drug use is rampant. And I don't anticipate, and I want to be very honest and clear with all of you as board members and in the community, that I don't anticipate us solving the drug issue or overdose deaths anytime soon. This is a generations in the making problem, specifically in Yakima County.
Andre, I don't think that anyone on this, I don't think that you misread. I think all of us are very concerned about it. But I would say, again, normalizing the use. I don't want to have a day come where I'm going to expect to carry Narcan and administer it on a daily basis, like I have to remember my bag to go to the grocery store. I don't want it to be where everyone normalizes it to the point where we think that we are going to encounter this situation. There's a difference between raising awareness about it and normalizing it. Normalizing brings to a standard condition of acceptance. And I saw that Councilwoman Duvall just made a comment about a different form of verbiage. Commissioner Anderson, you just suggested, I would be more than happy to work with Lillian. And if Councilwoman Duvall wants to take part, or whomever, maybe we can all just throw some ideas out there to Lillian. But I would just say that normalize is not the word, not the term.
Well, I'm sorry, ma'am, you didn't let me finish, and I would like to really share something honestly and directly with this board. And I'm happy, again, for different word usage, but we are absolutely trying to make this a regular use option. I understand that that's difficult to accept, but this is not something that just happens once in a while. It's not something that happens just to certain types of people. It's not something that happens at certain events. It is unfortunately part of our culture currently. And that's why we're trying to make it available.
Who's we?
We, the community, and I understood this board to want us to create a campaign to dramatically increase awareness of its necessary involvement. I mean, that's exactly why we created the campaign. That's what this board asked for.
And this board has input on how that campaign looks and feels. And I think we're providing you
don't
with some
disagree with
guidance
that.
right now.
And I don't disagree with that. And I'd really like you to allow me to finish, please. I'm just trying to share with you that, again, we can change the language, but I am committing to the idea that unfortunately, drug use in our community is rampant. We do have many deaths. I understood our board to be very concerned about the number of deaths and wanted us to move very quickly to ensure the integrity of a process that would allow people to live. We can deal with the reasons why they had a drug overdose after they survived, but the goal is to keep people alive. That's why we are talking about the distribution of naloxone. And I believe members of this board mentioned wanting to be able to have it, wanting to be able to have it in their home, wanting to make sure that if their children went to a party, that somebody there would have it so that if there was an accidental overdose, people didn't die. So I'm just being very candid with you that it is necessary to communicate its necessity. That's all.
Thank you. Commissioner LaDon has had his hand up for quite a while.
Yeah, well, first of all, just to note, Dr. Barg had a suggestion here about, maybe just changing the verbiage to increase availability of naloxone. I think most everybody here is aware of it, but Narcan and naloxone are the same product, and the term is just used interchangeably. Anyway, as far as the drug take back, I know, and I can't speak to other communities, but I know in the Sunnyside community, the hospital in Sunnyside has a permanent take back box there. It's right in front of the emergency department. And I believe the police department has something as well. So I know that there are areas of the county that do have these, available now and on a permanent basis.
Yes, and I would share, Commissioner Lindy, thank you. One of our goals when we started to encourage and allow the creation of these drug take-back boxes to be placed was to make certain it was in the lower valley as well. And we do want to make sure from an equity standpoint that it reaches all people. So thank you. That's a great point.
That box was actually one of the ones that we helped to put in. So thank you.
Dr. Atterbury.
I was just going to comment that I think we're focused on the wrong concept here, and that is the normalization of naloxone is to compare it to historically. We used to think of naloxone as being available in emergency rooms or in methadone treatment clinics or someplace where, quote unquote, there were high risk individuals. What we've come to know is that throughout our community, there are high risk individuals, and making naloxone more available to those individuals is of benefit to keeping them alive. So if our goal is keeping people alive, I think the normalization of naloxone is a necessary reality of the current environment that we live in. Now, I can encourage, like everybody on this board, I'm sure, primary prevention of drug abuse. That's a separate and noble goal, but the naloxone, I think historically doctors, physicians have looked at it as, oh, I don't need that in my doctor's office. I'm not serving that population. The reality is we are all serving that population, whether you know you are or whether you're not aware you are. And I just think that the normalization of how to administer naloxone, having it available, will prevent deaths. And we're most likely to see deaths in those areas where you didn't expect it. In other words, some teenage party where a kid overdosed. That's where you really want the naloxone available more than any situation I can think of. So I would just say the normalization, I don't think I take that language to mean the normalization of drug abuse. I take it to mean the normalization of the availability of naloxone. That is a difference compared to 10 years ago, compared to 15 years ago when I was doing my training. We really didn't talk about, when you give out a prescription for narcotics of any substantial amount, you should also tell those people, and I'm going to give you a prescription for naloxone just in case of what? In case your grandchild gets a hold of this, in case your neighbor steals it, in case whatever might happen, but just in case. And so that's an important point. And I think that's the normalization we're talking about. It's the normalization of the availability and the conversation that naloxone prevents death. That's my only comment.
Thank you very much, everyone. I think we've discussed that in depth. I'm going to move on to financial report. And Mr. Porter.
Got to take myself off mute. That's gotta remember to do that. So yeah, please, starting on page 19 in the Board of Health packet.
Are you, Commissioner Anderson, are you then still, you made the suggestion and we had discussed, I want to make sure we have consensus on moving forward. So we have consensus on moving forward with finding a different way to describe.
Well, I made a suggestion, and I think that you and a couple others are, Ms. Duval had volunteered or will volunteer to submit some language that can be considered.
All right, and I misread, it was Dr. Barg who had actually put that comment.
And Dr. Barg too, yes.
Yes, so I'd be happy to do that. I'm in agreement with what Dr. Barg had suggested, something along those lines, just not the word normalize, but it needs to be consensus from the board before we move forward.
All right. Well, is there a consensus among the board that we should look at changing that language?
I just want to clarify in terms of the specific language or the overall goal of the campaign. I think it's.
I understood the specific language of the word normalizing that verbiage there. Is that correct, Commissioner?
Yes, but I do think if there's other, I will say if there are, I think it would be important for this campaign, and we've talked about this at previous meetings, that if there are going to be, if there's a campaign and there will be, for example, posts on social media, graphics, I think it would be important in advance of those going out that the board was privy to seeing those, so that if we did have any questions or wanted to make recommendations on changing any verbiage, that we'd have the opportunity to do that before we go out.
I'm going to make a suggestion, Commissioner Anderson, if you don't mind, as board chair, that since we're actually having a presentation currently, that we adjourn this until it's my report, and then we could have a more robust discussion, if that's okay.
That's fine with me.
Thank you much. All right. All right. Well, we'll continue then with Mr. Porter and the financial report.
Okay. Good morning. For our financial report, well, first I'd like to start off with we are experiencing an audit currently right now. We had our entrance interview 2 Fridays ago on the 17th. Nyla was able to attend. So Nyla, thank you for that. So everything's going well so far, so good. We are hoping that they'll have the field work hopefully wrapped up by the end of this week, and then it has to go through auditors review and kind of up the chain. So it'll be a couple more weeks before this is wrapped up, and I'm hoping we'll be finished by the end of July. We'll have a report for you for the board. Moving into the financial statement, we had a very large gain for the month of May, $271,000. I'll get into some of the specifics here in a second, bringing our total access to $683,000. Our allocated revenue for through the month of May is $8.6 million, and our total actuals coming in at $5.6 million. And our expenditures, our allocated budget through May was close to 8.7, and our actuals at $4.8 million. Is there any questions about the summary? Next page, please. So moving into the income statement, do you mind zooming out slightly? Oh, that's perfect. Thank you. Just kind of looking at that, we're seeing big differences month and year to date for our revenue. And as you can see, that's all federal money. We're according to budget, it's $3.3 million, closer to 3.4. And that's directly correlated with the professional services other down towards the bottom. That's $3.4 million difference. And that's has to do a lot with our possible FEMA operations that we were possibility at the end of last year. You know, the accountant in me is not thrilled about these large differences, but the human being in me is, because we really planned and budgeted for the worst. We planned and budgeted that we would still be having full test sites and toll vaccination sites operating completely right now. So these large differences in actuality is very good for the community that we're, our financial statements are telling us that we are trending in the right direction for that. We're not needing the National Guard or the Army to come in and help us with those activities. Any questions about the income statement? Next page, please. Not necessarily a lot to note in the second half of the page. Any questions? Next page, please. Moving down into the programs, the big game this month had a lot to do with our MAC, our Administrative Admin claim. We had another big gain earlier this year that has to do with reimbursements for our highly compensated employees, our nurses, so to speak. So the MAC billing due to COVID has been in arrears. It's been behind. And as we catch up with that MAC billing, it is going to increase throughout the year. Typically, we've used this money to gets put back in for our wages for our highly compensated employees. Moving down, any questions about the program statement, first half? Moving down into the second page, please. We can see across the board, EH, Spring and Sprung, of course, there's a few programs in water and inspections that are kind of got a slight loss right now, but we're definitely seeing trends where it's going to start heading the other way as we head into the summer months. Our EH specialists are very, very busy right now. Any questions about that? All right, thank you. And now into our COVID income statement. Again, quite a bit different. We would have, we budgeted $14 million for 2022. And so far we've spent about 2.5. We're continuing to see operations. As we can see, we can have continued employee expenses and some small operating telephone expenses and of course, advertising. Last page, please. Looking at our cash flow, we had a slight uptick in cash last month. And I kind of spoke to that a month or so ago, how there was a delay in some DOH payments. You would think that, these large organizations, DOH, DSHS, everything would be clockwork and smooth, but they themselves are experiencing the great resignation, and there's been some hangups there. So that's kind of a little bit off the schedule. We'll see another uptick when we get our flexible dollars at the end of July. Any questions regarding the financial statements? Excellent, thank you.
Thank you, Mr. Porter. Hearing no questions, I will entertain a motion to approve the budget for May.
Commissioner McKinney, I would vote to approve the budget as presented.
Councilwoman Duval, I'll second that.
Been moved and seconded to approve the budget as presented. Mr. Ibach, would you like to conduct a poll, please?
Yes. So if you're in favor of the approval, please state yes. If not, state no. Commissioner McKinney,
Yes.
Commissioner Lindy,
Yes.
Councilmember Byers,
Yes.
Dr. Atterbury,
Yes.
Councilmember Duval,
Yes.
Commissioner Anderson.
Yes. Thank you all very much. We'll now move on to the agency reports and Executive Director Andre Fresco.
Yes, thank you so much to the board. Good morning. I wanted to begin by sharing my thanks both personally and professionally for all the hard work of the board in allowing us to come to an opportunity to have new board members through the 1152 process on time, within deadline. I know it's been a great deal of work for all of you, and your commitment and willingness to be part of the interview process and understand the complexity. Just grateful because it has been a great deal of work. So we will have 2 new board members. We have 3 openings, but 2 new board members officially who will be appointed, Stephanie Algren and Daleen Ackerman. If you don't mind, I'd like to defer to Ryan at his report so he can go into specifics for you. But I do want to thank you for that process. The July 1st deadline was always going to be very tight to meet. was always going to be complex, and it's been a very ambiguous process. 1152 as a bill was not a very well written one in terms of explanation. And so the interpretation has been complex. So my thanks to the board again, to the staff, and certainly to James Elliott for his counsel. But we have succeeded in doing so. So thank you all. And again, Brian will go into specifics in his report. So if you have questions, if we could hold those until then, if you don't mind, unless there's something specific I can answer.
I would just like to thank everybody too, because it was an arduous process to get done in a timely fashion. A lot of details and a lot of interpretations to resolve, and we got it done. And thanks to everybody who put in the time and the effort and made the presentations and participated in all of this. It's very sometimes a thankless job to do these kinds of things, but we got it done, and we're going to move on and have a really strong board in the coming months.
Thank you. I wanted to mention that we continue to have high COVID numbers in our community. What we see now are strains that are highly infectious, more easy to catch, but fortunately less deadly, certainly less dangerous in terms of hospitalization. So hospitalization numbers are not high, deaths are not happening currently. I will share though that the advent of at-home testing has meant that many people are testing at home, which is great, but not being tracked, which is not great. So the numbers that we have in terms of who is positive in a community, I think is decidedly low, because people are taking at-home tests and making decisions and therefore not being tracked. But again, the availability of testing for free at home has been wonderful in terms of keeping our community safer. So you'll hear more from Melissa and Dr. Bart, but I did want to share with you that we continue to see high numbers, and we are planning as a health district for the fall for return to school. Our hope is that we don't have a new strain that is difficult or deadly or dangerous, but again, we'll know more soon. But there will be more to share in agency reports. Unless you have questions for me.
Any questions for Andre? Hearing none, we'll move on to Dr. Barb.
Oh, no, if I may, Commissioner Anderson, I apologize, but since we had adjourned on the issue that had been raised by Commissioner McKinney, I wanted to address that.
Okay, right. Okay, go ahead.
And if you don't mind, I believe there were people who still had questions. I don't know if you'd be willing to entertain those questions now, sir.
Well, might as well.
Okay. I believe I saw Councilmember Duval, and I don't recall, but I thought there was another hand up.
I think it was probably mine. I had a question that I just agreed to defer to later.
Okay. Anyone?
Well, I did have a question, and I'm okay with not going into depth, because I really did echo what Dr. Atterbury had said about normalizing naloxone, as far as it being normal to have and accessible, just like an EpiPen. That's the way I see it. It saves lives as long as you have it there with you. And I wanted more information about what it means to have a standing order. I've heard of that before for naloxone. So if you can go into depth, if you need a prescription for it, or how much does it cost? Is it free? How would somebody get it if they knew somebody or were close to somebody that is using drugs and wants to have that available?
I defer to Melissa or Dr. Bart to define standing order better than I would.
Yes, sir, Dr. Barb. So the Department of Health has tried to make naloxone or Narcan accessible to anyone. And so they have what's called a standing order, which means that you don't need a prescription from your doctor to obtain it. Any pharmacist can provide Narcan to an individual who requests it using the state's what they call standing order. So it's a physician's order that works like the prescribing that to the individual requesting it. So you can walk into any pharmacy that carries Narcan and ask for a prescription, and the pharmacist is allowed to give that to you based on a standing order. We have done some looking at data to see which pharmacies have it, how much they have, and I think, Lillian, I think you want to touch a little bit about that on your presentation, but what we're finding is that not all pharmacies have it, and they don't have a large, if they do have it, they don't have a large amount. So we know that when we get this messaging out there that Narcan's available, it's covered by most insurances, it's covered by Medicaid, 100% by Medicaid. When the information gets out there, we will need to see an influx of Narcan come into our community to be able to support everyone that wishes to obtain it. So I hope that answered your question, but we are, Lillian, it's kind of Lillian's department on the social media and putting things up there, but I believe we have up there how the 3 different ways you can obtain it. Correct, Lillian?
Yeah, that's part of the messaging is describing what the standing order is, what the situation is to different pharmacies, and kind of going through a step-by-step on how someone can go about getting it. That is part of the campaign.
And on the other side of that, we've sent out messaging to our providers to discuss the best practices on whenever you prescribe an opioid to your patient, a narcotic, that you are prescribing Narcan to go along with that. Just like Dr. Atterbury said, you're not necessarily concerned about the patient overdosing, which they could, but anyone who would come in contact with that prescription. So,
Thank you. Dr. Barg?
Yeah, so Dr. Atterbury, I think, elegantly stated why all this stuff needs to happen. And when you have a standing order, it's a protocolized series of events that have been reviewed by physicians and deemed to be safe and effective.
Thank you.
Thank you.
Dr. Barg, your comment was to increase availability and awareness. So can we agree on something along those lines, that our goal is to increase awareness about the availability and to increase availability?
Both I say would be necessary goals.
Mm-hmm. And I completely agree with all of the sentiment statements that have been here. And I think that that's we can choose our words and articulate that specifically. And I think that accomplishes what the goal is.
Very good. And I wanted to share, and that's why I'm glad, thank you, Commissioner Anderson, for allowing me to have the time to hit on this. What we're dealing with are community issues that are very complicated, very painful, and don't often align with the reality of what we want for the community that we live in, are committed to, and love. These are very painful issues, and the issue of drug use and drug use within families is very painful. We see people who are holding down jobs, are very much part of the fabric of our community, who nonetheless have addiction issues. So again, I want to share with you that we are not promoting drug use here at the Health District. What we're trying to do is save lives and make options available for people. But I will share with you candidly that these are very hard conversations. These have been very hard conversations for generations. And what we are attempting to do is to illuminate, to bring options to people so that they are safe. And so we're doing that on behalf of the board as well, because that's something that was brought to our attention as a very big concern. But I do want to ask for all of your support in that these are very tough questions. We are in a crisis with drug use in our community. And so we're not trying to move quickly to avoid these communications. They're robust. And I think that there will be many differences that we'll have to overcome collectively. I share with you, though, that candidly, what we're trying to do is create options for people. And that's one of the discussions. And so when we talk about standing orders, it's not just a medical term, it's allowing for the availability throughout a community for free also. And that's one of the things that we don't want to have stand in the way for people is cost. So thank you again for the conversation. We're open at the Health District to changing language, but I do want to share my concern that what we don't want to do is to avoid our ability to help people. Thank you.
Thank you. All right, we will now move on to Dr. Barg.
Commissioner Anderson?
Yes.
So I had been waiting for a follow-up on the conversation, if I may. Yeah.
didn't see your hand up. I'm sorry. Thank
No,
you.
I had taken it down just to wait.
Oh.
I'm sorry. So my question was about, do we have any information on how many times an individual receives Narcan? Are we tracking that at all? And here's a broader question. It probably maybe should go to the legislature rather than the health department. But the legislation coming out last year legalized open use of a lot of narcotic medications, a lot of things. And I just see this as adding to our situation, very unfortunately. And I'm wondering, if somebody is using alcohol and whether they harm anybody else or not, if they're picked up on a DUI, there's a legal system they go through after so many offenses, to be forced into some kind of treatment or something. I'm wondering if we can somehow even talk to our legislators as a group, as a board that says we would like to see a reverse of some of those decisions, and we would like to see opportunity for people who are repeat offenders to have some legal options available to get them into treatment.
Councilmember Byers, I think, as you said, that would be a legislative question, but your question specifically about Narcan, and I think Melissa can go into more detail. We have a very robust process to keep people HIPAA compliant at the harm reduction site. What we do actually track, and a part of our relationship with the University of Washington and originally receiving Narcan when it was very expensive and not readily available, but we wanted to get it out to people. And also, frankly, to get it out to our partners, police and fire and so forth, was to be able to track overdose reversals. And so we have been able to show that using Narcan or distributing Narcan has resulted in less reversals. I think that it would be fair to say that if somebody says that they used or witnessed a overdose and used Narcan and wanted another, they could receive it. But Melissa, if you'd like to go into a little bit more specifics, and that can be part of our discussion when we have our spotlight next month.
I would like to interrupt this for a minute. Commissioner Lindy's had his hand up for a while.
Oh, I'm sorry.
It's okay. Listen, I wanted to piggyback on something that Councilmember Byers said that I think is important. There is an alarming change to state law regarding drug possession, and it's starting to take effect, but the full effect will take place in a year, when any drug possession law will just simply be an issue referring to treatment. It won't force them into treatment, but it refers them to treatment without any legal ramifications whatsoever. And the people that I've spoken to that deal with those suffering with drug use have stated unequivocally that for people to make changes in their life, there needs to be a hammer to make them take stock of their lives and the direction they're going. And so I liked Patricia's idea of maybe the health board making a statement or request to the legislature to reverse the direction they're going on the drug possession laws, so that there is a way to make these the drug users and addicts take stock and have an incentive to want to change their lives.
Thank you.
And Commissioner Anderson, I know that Commissioner McKinney has her hand up too, and I would happily address that after she's shared.
Okay.
My comment was actually going to be exactly that, that I have routinely participated in observing drug court. And when you speak with people who finally were engaged into the system, it was because there was a big stick and they were given, a choice. And sometimes it takes being put in a position where you have to make a difficult decision. In this case, it was avoiding significant amount of time in jail, prison, and financially, obviously, some pretty significant constraints there that would have been placed on them. But they will repeatedly tell you, if you're in drug court, there are people who they're begging to get in. They're begging to get into drug court because they think that it's the only thing that would keep them alive. Because there are so many programs out there that are there to just give them what they need to continue to abuse drugs. And so I would encourage anyone, it is open to the public. You can go to drug court and listen to these incredible people tell their stories and share every day how difficult it is for them. There are stories of people who are assigned to go to treatment and they're supposed to report at 3 o'clock in the afternoon at 9 a.m. and they go straight there because they are so worried that they will abuse in that short time frame and not follow through with the program. It is significant. So I would just say that, yes, this is a society where in Washington state, our legislature has gone completely the wrong direction. And I would also be supportive of this health board making a statement to our legislature to that end, asking them to reverse their course and to encourage a change in the laws, reverting back to there being some consequences, because that is truly how people are enabled to get help that they need to get off of these really addictive drugs.
I would, oh, I'm sorry, after you, Commissioner.
Oh, I thought we were ready for Lillian.
No, I do feel, I understand people's concerns, and I think that many times we've seen a reversal in the state to the point where things have become quite casual, which concerns me in terms of drug use. But at the same time, I would also be remiss if I didn't share with you that the drug epidemic in this country happened and was created during some of the most strict drug enforcement and legal oversight and penalizations and incarceration that this country has ever witnessed around drugs in the 80s and 90s and early 2000s. And that didn't stop the drug epidemic. So I would share with you that the threat of incarceration may be a tool for some, but it doesn't stop our community from having a drug problem. So I understand your interest in directing information to the legislature, which is your right, but I do also want to share statistics because as Dr. Atterbury mentioned earlier, it's a blended process, and I would be remiss if I shared or my own position that simply having more enforcement at the legal level is going to change our drug issue in our state.
Okay, Commissioner Lindy.
Yeah, and Andre, I appreciate your perspective, and I think there are people that we won't change, but if we can say, if we change 20% of the people, then we've changed a lot of lives and probably future generations as well. I mean, I understand where you're coming from, but I do think there are people that we can help. And anyway, it's I think what we're asking for is it's probably that part's not a health district thing per se, but an action that the health board can say, which would be an appeal to the legislature.
And Commissioner Anderson, I see Commissioner McKinney's hand is up.
I was just going to ask if Councilwoman Byers would like to make a motion.
So I guess I would make a motion that the health board would put together a letter addressing the issue of the legality of drug use and legal follow through with that to the legislature, asking that we revert to the use of legal. I guess it's kind of a long motion, isn't it? I'm sorry. Let me rephrase it. I'm wandering here. So I would make a motion that the Board of Health would submit a letter to our legislature asking for reversal of some of the recent legislation that legalized open drug use.
I would second that motion.
Moved and
Oh,
seconded.
you beat me to it. I was going to say, okay.
Any further discussion?
And I would just want to make sure that we're not using the health district staff and time for this, since this is a Board of Health request or motion came about from the Board of Health, and I would suggest that somebody from the Board of Health write the letter.
I would. Any further comments on that?
I'd be happy to assist with that. I don't know, Patricia, if you wanted to.
I'd be happy to assist with it as well. I don't think I'd want to do it entirely on my own. So
I think 2 or 3 board members would be excellent to do that. Put together some draft letter and then submit it to the board for a review.
Well,
Yep.
if you mind me suggesting this, since since myself, Councilwoman Byers and Commissioner McKinney have commented on, perhaps the three of us could put our heads together on it.
Sounds great.
All
Yep.
right. Mr. Hall, would you like to participate in that as well?
Me?
Yes.
No.
Okay, thank you. All right. So I don't know if we need a motion or not, but
Yeah, we've already had a motion and a second, so call the question.
yeah, so the question is, write a letter, draft a letter and submit it to the state legislature for consideration of, we want to restate it, Council Byers.
I didn't write it down, so did anybody write it down?
Ryan may have some language. Hopefully Ryan has some language.
So the motion generally was that the Board of Health submit a letter to the legislature asking them to reverse some of their decisions last year to legalize drug use.
Okay, thank you. And we have 3 volunteers to draft a letter. Mr. Ibach, would you like to take a poll, please?
Yeah, just for a point of order, Commissioner Anderson, this was not an agenda item. I don't know if we need to ask our legal counsel, Mr. Elliott, whether or not this would need to be put on the next agenda item for an actual vote.
Well, do we get to go back to the question of whether it's an emergency or not and discuss that issue? I mean, I previously the board had that sort of as the process under which you would go about doing these motions and items that weren't on the original agenda unless it was an emergency. So, I mean, I think the prudent course, considering this isn't a time sensitive issue, would be put it on for the next meeting, sort of maybe work through the discussion then, but that'd make the most sense to me. But whether someone wants to argue it's an emergency. What's that?
I'd like to amend my motion. Yes, I'd like to amend my motion. Thank you, Mr. Elliott. So I would like to change my motion to put on the next Board of Health agenda a discussion and hopefully a motion regarding writing a letter to the legislature.
Does a second approve of that?
No, I don't. I think this is a fine example of a rule that we've created that hampers our ability to conduct the business of the board. It is often that things like this come up. We can simply vote that this is an emergency. Obviously, if we delay this any further, then we already have 3 people who have volunteered who are going to write this letter and bring it back to the board before we actually see movement on this. What we're already agreed upon is that we're going to have draft letter to be sent to everyone for approval. So I might say that we could consider this an emergency to allow the 3 people to work in the meantime to draft the letter. And then at the next meeting, we can vote on approval of the letter.
Mr. Elliott?
I'm not sure I can say anything different, Commissioner. If that's what the board wants to do, obviously it can. Was sort of recapping where we were from before.
Right.
If my memory serves me well, Commissioner Anderson, what happened in previous discussions like this was that the board had to decide as a board whether it was an emergency or not.
Yep.
So I would make a motion that we vote to determine if this is an emergency.
Well, I just want to point out that she made an amendment to her motion, and I'll second that motion that we postpone it. So you got ahead of yourself with starting the discussion.
Mr. Elliott, may I ask that, I did ask to amend the motion and now there's a second. However, the second to my original motion also is allowed some discussion on that. So what has precedence here?
My suggestion might be because, and we do this sometimes, when we're trying to work through process, it might make more sense to sort of start over, if we will, in terms of what we're trying to figure out here. There had been some discussion related to it, no votes taken on each. To the extent that there wants to be you want to have a withdrawal essentially of what we've done thus far and start over, that might be the easiest way to do it.
Who would do that?
What's the process for withdrawing?
I think Councilwoman Byers, it was your motion, correct?
Correct.
That's correct.
Yeah, so, I mean, I think to the extent that you want to withdraw your motion here, considering you had some discussion, but no action was taken on it, you can withdraw your own motion. Then we can sort of start all over from a new process. It sounded like Commissioner McKinney also wanted to have a motion potentially on this issue. So what I'd suggest is you essentially withdraw your motion, Councilwoman Byers. Then to the extent that the board wants to start over again with a new motion, we go from there.
Then I withdraw my motion.
Thank
I
you.
withdraw both of my motions, the motion and the amended.
All right, thank you. Now, start over then.
I would make a motion that we consider this issue an emergency so that we can hold a vote on whether or not we would like to write a letter.
Is there a second to that?
I'll second that.
It's been moved and seconded to consider writing a letter an emergency. Mr. Rybach, would you like to take the poll, please?
Yes, so if you're in favor, please state yes. If not, state no. Commissioner McKinney,
Yes.
Commissioner Lindy,
Yes.
Councilmember Byers,
Yes.
Dr. Atterbury,
Yes.
Councilmember Duval,
No.
and Commissioner Anderson.
Yes. All right, it's been approved to consider this an emergency. So now we can make another motion, whoever wants to draft a letter to be presented at the next board meeting.
Commissioner Anderson, I would move that we put together a group of the board, as we've named before, to draft a letter to be sent to the legislature regarding a reversal of course on our drug possession laws.
I would second that.
It's been moved and seconded. Is there any further discussion on that?
I just would like to point out that the motion said that it would be a draft. And hopefully we can get some community input and public comments at our next meeting.
Yes, I would, that's a good comment. Mr. Ibach, would you like to take the poll, please?
Yes. If you're in favor of the motion, please state yes. If not, please state no. Commissioner McKinney,
Yes.
Commissioner Lindy, Councilmember Byers,
Yes.
Dr. Atterbury,
Yes.
Councilmember Duval,
Yes.
and Commissioner Anderson.
Yes.
6-0.
Thank you. And I think, I don't think we need a vote on this, but I think the volunteers are Patricia Byers, Commissioners Lindy and McKinney.
Correct.
All right.
May I just mention, Commissioner Anderson, in closing on these issues, that I suspect we've had it in the past with COVID. We've had it now with this issue. I think that there may be times when the interests of our Board of Health members to position conversations about what they feel should be different may be different, and I share this politely, may be different than the work of the health district. So I share this with you candidly because, again, we are in crisis on multiple fronts in our valley. Our goal at the health district, again, is to advance the conversation to further opportunity to create fairness for everyone to receive the services that they require to live safely and well.
Right.
So that's something I just share with you again, because I know some of these conversations can be difficult, even divisive, which I welcome. But I do want to share that our job every day is to be able to serve the best interests of our community members. Thank you.
Thank you. And I think we need to remember is that we will have at least 2 more members of this board at the next meeting. Commissioner Lindy.
Yes, in the midst of all this, I just want to thank everybody for the discussion. I mean, I want to thank Lillian for the presentation, because that's where this all started. Obviously, it's a big issue. It touches our valley in a big way. I think with public safety, drug use and addiction are our biggest issues. And so I appreciate you bringing the information to us. It's helped spur a very lively conversation, obviously, but they're important issues and lives are at stake. So thanks for the information, Lillian.
All right. Well, so before we move on to Dr. Bard, Lillian, I think you had a follow-up through Mr. Fresco? If you don't, that's fine.
No, the only thing that I will share, actually, we just got the information. I think it was Dr. Atterbury that asked about the differences in Yakima County and statewide rates. So for Yakima County, it's 23.1 per 100,000 rate of death versus statewide it's 18. And then when we look at opioids specifically, it's 15.9 in Yakima County versus 12.1 statewide. So we are higher than the state. And some of the other information I'm happy to follow up with over email. Thank you.
Lillian, would you put those in the chat, please?
Absolutely.
Thank you much. All right, I think we're ready to move on to Dr. Barg.
Good morning.
Good morning.
So in follow-up from last meeting for Dr. Atterbury, we have some data about avian flu. And this is maybe a week and a half old, so there may be additional flocks that have been involved, but we had 3 in Yakima County. And all 3 have been dealt with by the Department of Agriculture. And I do want to enhance that these issues are really for the Department of Agriculture. One good thing is that none of these exposures, when there's been a human involved, have resulted in human disease. There's also been some wild birds, some red-tailed hawks that have been identified with the infection. So the Department of Agriculture is heavily involved monitoring this and taking care of the issue when a flock has been found to be infected. And that's about it, Dr. Atterbury. If there's anything else, we can dig for it and move forward from there.
No, I
I'll just add
appreciate
that we
you
had one
following up,
additional
Dr.
one.
Barg.
I'm sorry. Oh, I'll just add, we did have one additional flock reported to us yesterday. So we have 4 total between Selah, Sunnyside, and East Valley.
Okay.
All right, so we'll move over to human centered things. COVID, as Mr. Fresco suggested, is increasing in numbers and does that, it's probably an underestimate of how many people are actually infected. And some people in the last several months, some statisticians and healthcare providers, hospitals, et cetera, have really wanted to focus on the number of people that have to get hospitalized, because that's where the system is taxed, other than people who are missing work that aren't sick enough to go in the hospital. So what we're seeing an increased number of hospitalizations. And unlike a year ago, where the activity was so high, it was difficult to tease out who was in the hospital for COVID and who isn't. It's actually fairly easy to do that now. And many people who are hospitalized are incidentally being found to have COVID. And that also goes along with how much treatment is being administered to people with COVID. And in contrast to, again, last year, when 3 or 4 people a day were being administered drugs like remdesivir and baricitinib, there's only been 3 administrations in the last 2 weeks of that drug. None of the baricitinib has been administered, which is given to people that are seriously ill. And there's been nobody on vents, at least at Memorial. I don't know about Toppenish and Sunnyside. There have been 6 people in the hospital that have received bebtelovimab or Paxlovid, and those are agents given to people who normally would be outpatients. But these were folks admitted to the hospital with other problems and early enough in their disease that if they had been outpatients, they would have received these drugs. So the hospitalist and Dr. Lee, who is another infectious disease person that works with me, have been cognizant of these issues and are taking measures when necessary. All of these people that receive those treatment ones do not require oxygen. So if you're sick enough to come in the hospital and require oxygen, that is not considered. And I think I'm correct saying we've had no vents being used to treat serious COVID. So the downside is there's more cases. The upside is so far, there's not an increase in seriously ill patients. King County is also seeing an uptick in the number of patients hospitalized. Don't have specific data about how sick they are. Another topic that's percolating in the news is monkeypox, and the numbers are increasing, but The WHO has not yet considered this to be an epidemic in range. We'll see what happens over the next few weeks. If you're old, you've been vaccinated with smallpox, and smallpox will protect. There are also, as we said last meeting, the vaccine is available and it is being ramped up and will soon be distributed. There's also an antiviral that's available. I haven't heard any information about that being ramped up and distributed, but it's certainly possible. So from infectious disease aspects, that's the latest on what's going on with flu, smallpox, and COVID. So three viruses. I could be, amazed about how difficult viruses are to deal with. So that's my report.
Thank you, Doctor. Commissioner McKinney.
I am really grateful to hear the update, Dr. Berg, that you just provided about the ability, because COVID is not impacting people at such a rate of significance, that you indicated that it is now easy to determine those people who are hospitalized with COVID versus because of COVID, which of course is something that I know that I've really felt was important for the public to know for quite some time. And so I wonder if your comments stating that it is so easy to know, that we could, Nathan, reach back out to Memorial and to Astria and ask them to begin to tell us the difference so that we can reflect that in our sit rep, so that we can accurately, as a community, gauge the risks of COVID for hospitalization, because it certainly is very important. And I think what comes to mind, had always come to mind for me as parents with young children. We see young children in the hospital, and be really reassuring to a lot of those parents to know that it was because those children presented because perhaps they had a broken leg or something along those lines, versus because they were so severely ill with COVID that they were hospitalized due to COVID. So I'm wondering, Nathan, if you could reach back out and ask for that data so we can start to see that.
I will certainly reach back out to the hospitals and let you know what they say.
Thank you, Nathan.
Thank you, Commissioner. Any other comments or questions? Thank you much. We'll now move on to Chief Operating Officer Ryan Ibach.
All right, so an update on our new Board of Health members. Happy to say that yesterday, the Board of County Commissioners approved and appointed 2 new Board of Health members. So position number 3, theater stakeholder, community stakeholder position. Stephanie Algren will fill that position, and she will fill a 2.5-year initial term. And then the position 4, which is the consumer public health position, will be filled by Daleen Ackerman, and she will fulfill a 4.5-year initial term, so that we can get these 2 new positions in alignment with other positions as agreed by the Board of Health. So officially on July 1st, they will begin their terms. And so this Friday, we'll start sending them all the same correspondence that we send this Board of Health. They'll get the weekly sit reps, they'll get any other information, press releases in advance. And then we'll also make sure that they get into an orientation, Board of Health orientation before our next meeting. So they know what the Board of Health, what public health looks like in the state of Washington and Yakima County.
And Ryan, will that also include that orientation? Will it also include a physical tour of the office?
It absolutely can, yes.
I think that would be good.
Okay. Any other questions before I move on to the next item?
One other thing the board should consider is, as we had identified before, that once the new board comes online in July, there would be a new chair who would be put in position. So I can't remember the language from the county commissioners ordinance, but I know our discussion in prior times was once the new board is online, there would be an election for a new chair to take place at that meeting. And county commissioners, correct me if I'm wrong or if I'm overstating that position, but I think that should be on the next meeting as well.
And Mr. Elliott, I can tell you that that is reflected in our ordinance that we passed, that language.
Yes, and if I may also share with the board just an awareness that once those appointed members officially join our board, our quorum will change as well. So when we have 9 members of that board, we will have a quorum that has to be 5. Thank you.
And Andre, does that reflect the fact that the Native American member will always be missing until appointed?
Correct, yes. And James, we discussed that, but please, if you'd like to share that, I'm happy to have you do so.
Yeah, to the extent that until that member has been placed and selected by AIHC, this board will operate as a 9-member board. And for quorum purposes, that will be the number used until the 10th board member gets appointed. Once the 10th board member gets put in this position, which we are still waiting for a response, I believe, Andre, correct me if I'm wrong, from AIHC. Once that selection has been made, that board member will get added. We then will be a 10 and our quorum will number, I think it changes because I think we'll go from 5 out of 9 as opposed to 6 out of 10. So.
Yes, correct. And we have not had official correspondence from AIHC about that. So I anticipate that we may not have that position filled before the July 1st deadline. Is that correct?
Would you like to continue?
Sure. Yes, and so also the next item is then the, since we're at the end of the school year now, just wanted to give you some COVID data on what we saw in the schools for the 2021-22 school year. So a lot of this data that I'll be presenting is the same data that you were receiving the weekly school data reports. And so you can see, just want to go over the first figure is the number of students that had COVID while at school. You can see where we started out at the beginning of the school year, kind of up in numbers, and then we had that surge in January, February in the winter, and then it dropped down. We quit doing the weekly reports sometime in April when we were pretty low, and then you can see at the end of the school year, we started seeing more cases of students actually in school. Not quite as high as the beginning of the school year, but we did see an increase. The next figure is the number of staff with COVID-19 at school while at school. Again, it's kind of the same trend where we saw at the beginning of the school year, we saw a little bit higher numbers, but then we saw that surge in the winter, and then we saw an increase at the end of the school year. And we actually, in the staff, it's interesting because we did see a higher increase at the end of the school year than what we saw at the beginning of the school year. If we move on to the next figure. The next figure is just the number of on-site transmissions, confirmed on-site transmissions. So again, same trend, beginning of the school year, we saw some on-site transmissions, saw quite a bit in the middle of the school year, and then we saw an increase of actual on-site transmissions at the end of the school year. And then this last figure, or the last chart, is just the vaccination data from 5 to 11-year-olds. So you can see that we've had 6,442 total vaccinations given from 5 to 11-year-olds, or people vaccinated from 5 to 11-year-olds. You can see, and all this information we'll send to all the board members, so you can take a look at it more in detail. But we have the male and female, a little bit higher on the male. You can see the ethnicity, fully vaccinated of those 6,442 people, 5,393 have been fully vaccinated, and 1,049 have received their first dose. Any questions?
Any questions? All right, well, thank you. We will now move on to Mr. Nathan Johnson.
Before we do that, Commissioner, can I just say, first of all, thank you to everybody, county commissioners, everybody involved, staff, in terms of the process we had to go through for the appointment of board members. If you'll remember, this has been a long process with many different challenges. From a timeline standpoint, we had to push things. I know people didn't like me pushing sometimes as hard as I did in terms of getting things done, but I just want to thank everybody for doing this. I'm thankful that our board will be compliant by July 1st related to the requirements that were put on us by the legislature. And just want to make sure everybody understands, appreciate understanding and willingness to work through that before we move on, Commissioner. Thank you.
Thank you, sir. All right.
Just real quick update regarding COVID vaccines. Earlier this month, it was approved for Moderna for it to be 6 months to 5 years old, and then for Pfizer for 6 months to 4 years old. Those vaccines have since started rolling out to providers. We're really pushing the community to go visit Vaccine Finder and utilizing that site as a source to find where the vaccine may be available. There was some glitches at the beginning of this, delays in shipments. That's since been resolved, and we're seeing more and more providers add on to that list that has that vaccine available. We're also working on communicating out with providers, letting them know that it is available for them to order as they see fit. Just also wanted to touch on earlier this month, June 6th or 13th through the 15th or 16th, I'm sorry. YHD participated in the statewide Cascadia Rising exercise. The last time that the state put on this exercise was back in 2016. It was broken into 3 breakout rooms: the coastal counties, the I-5 corridor in Eastern Washington. So we participated in coordination, not only with Yakima Valley Office of Emergency Management, but Benton Franklin and Walla Walla and other counties throughout Eastern Washington as part of this large statewide exercise. A lot of good, productive conversations. Again, this is all centered around the planning around a large catastrophic earthquake that will run from Canada all the way down to California, causing significant damage, specifically to the west side of Washington, and making things look very different for Eastern Washington counties. So we really focused on critical transportation routes throughout the state, as well as mass care. So we talked a lot about large sheltering operations, including feeding and hydration as well. So it was a good conversation, a lot of good outcomes from that. And it was nice to see that a lot of lessons learned through COVID, we can definitely apply to another large disaster. So we'll be continuing working with local and state and federal partners, for that matter, around planning not only for Cascadia Rising, but certainly other disasters that may come our way. And that's all I have.
Thank you, sir. And I hope not, but I do have some beachfront property coming soon to your neighborhood signs available. Guess that didn't go over very well. Anyway.
I was laughing, but I was muted.
Let's move on to Melissa Sixberry.
Good morning, everyone. So for active TB cases, we're currently managing 4 patients, which is an increase from last month, I believe there was 2. Total since January 1 of this year, we've had 5 active TB cases that we're managing. So sometimes we've had one that's left the state and moved, and then we've also had a couple that we've discharged from care. They've completed their treatment. We're still continuing to see our syphilis outbreak. So we are piloting a program with the Department of Health in a way for other counties to learn. We will be using rapid syphilis tests and doing outreach testing, specifically the population that we're seeing the syphilis in, which is our homeless and drug using population. So when we find those we do a rapid, which is a screening, we can know within 15 minutes if somebody's positive for syphilis, so we can treat them on the spot to try to prevent further spread. And also because we're seeing this more in our drug using and homeless population compared to previously in years past, it was mostly seen in men who have sex with men. Because we're seeing more in women now, it's also what is contributing to our increase in congenital syphilis cases, which is the syphilis in unborn babies. So we're going to continue to work with the Department of Health on that. And then also we picked up our new motor home, I believe it was last week or the week before. So we do have some pictures. We're very excited for our new mobile platform so that we can reach community. So this is not the new motor home. This is the old one. This is what we were running off of, which was a 23-foot 2002 motor home. And you can see it was faded. It's missing hubcaps. It was in pretty bad condition. It was shaking all over the place when we drive it down the road. So I appreciate the board's approval for us to invest in a new mobile platform. Next picture. So here is our brand new 31-foot motorhome that has 2 slides. So that's showing one side of it. Go ahead, Jesslyn. Here's the other side of it that has a slide out as well as a powered awning. Our staff would be out there manually pulling down an awning before. So this provides shade when we're doing education outside. And you can also see there's a TV on the outside, which allows us to display information when we're at health fairs or community events to be able to say, to publicize health information out there. And then inside the motorhome, in this little section on the bottom picture, is what was a bunk bed. We had them take out the bunk beds to make more of an educational space for us. So it's just one of the areas in the motorhome that provides for a place for education for us. Next picture shows kind of the main area, which also allows for education. You can see in the bottom picture, there's in the overhead part, there's a TV up there as well. So we have more areas where we can provide education and videos to individuals. And then in that top picture, you can see there's a solid door that goes back to what was the bedroom. And we had that transitioned into more of an exam room. And that solid door helps provide privacy. Yep, go ahead, Jocelyn. And so here's the exam room, which was a bed, had a queen size bed back there, is now a place where we have a phlebotomy chair where we can draw blood. We have a TV back there to provide education. It's a privacy room. We can administer vaccines back there. We can have our resident physician out there doing basic wound care. So it provides a lot of room for us, and the staff absolutely love it. So I think that was the last picture, Jocelyn. And there's one more. That's it. And that's it for my report, unless anyone has questions.
Melissa, we should get that thing fired up for the Toppenish Rodeo and get it tried out.
We've actually been using it. It's been in a couple of events already. And so we're still in the process. We still need to get our decals put on there so everyone knows it's the Yakima Health District representing. But yeah, we've been in several events already, and it's been really nice. You know, the staff made comment that last week they had the air conditioning on and it felt great. The old motorhome, the air conditioning wasn't really running. So when we would be out there, 95-degree weather, it was pretty uncomfortable.
Commissioner Anderson, I want to recognize that Councilmember Duval has her hand up.
Right. Yeah. Thank you.
Melissa, you showed us pictures of the mobile unit. The outside, are you guys not planning on getting it wrapped with the health district logo?
Yes, we are. So that's one thing that we still are going to be working. We just got this 2 weeks ago in our possession. So that's something now that we'll be getting quotes on to have decals put on and working with our communications team on what those decals will look like. And yeah, we're excited. So
I'm excited too. I hope that you guys get that done. Thank you.
Councilmember Duval, we were looking at a full wrap, but to be fair, it's the people's money, and it was dramatically expensive to have everything wrapped, which was not going to work for me in terms of how we invest government dollars. So, I do want to share though that we will have decals and we will have images. Also, again, we were able to, thanks to Melissa and Ryan, really bargain for a significant savings when we purchased it. And as Commissioner McKinney said, we should have a warranty on it. So we have a very long warranty. The goal, again, is to have a mobile platform that's safe and reliable and can be used throughout the valley to, again, we're a very large geographic area. We want to be able to reach everybody in every community. So thank you.
Thank you much. Do you have a further comment, Ms. Duval?
No, thank you.
Anyone else have a comment or question? If not, we'll move on to Mr. Sean McGee.
Oh, had to find the mute button there. Hello, good morning, everybody. Not a ton to update on, but we are in right in the middle of our busy season. Our land development programs are running at full capacity right now. I am happy to update that a lot of our newer staff has gone through quite a bit of training and out in the field and here in the office across all of our land development programs. So we do have more individuals working independently in those programs than we've had in the past, which is keeping our response time to go out in the field and do inspections, typically under a week, which for this time of year is at times been not happening. So really happy that we're being responsive to the community and to the applications that community members are submitting to us, so we can get their projects moving forward and not be a barrier for them. So really excited about the work we're doing during this busy season. And the other update I have for Guama is for Guama. We're continuing with the potable water delivery services and still meeting as an implementation committee with several other agencies, looking at what other action items will be implemented within the Guama. Not all of them necessarily involve the health district, but as a member of the implementation committee, we do have conversations about those other action items. One of which is the possibility of bringing on a Guama coordinator. So a person that would oversee all the projects and implementations for the groundwater management area in the Lower Valley. Kind of a central hub to keep everybody on task and keep all the information and efforts organized in one location. So we're pretty excited about that moving forward. That's really all I have to update for this month.
Thank you. Any questions or comments for Mr. McGee? Thank you, sir. Appreciate it. We'll move on to public health partnership with Lillian Bravo.
Thank you. As a department, we're continuing our routine work with closing out the contract year. Our largest programs is the breast and colon health program and developmental disabilities program. So we're also continuing to assist with communicating changes on the vaccine recommendations and working with community-based organizations to make sure that rapid test kits are readily available, as well as hosting vaccine clinics when people are interested, helping them coordinate that. As an agency, we're also participating in several community events throughout the summer, which I know at times we run into several of our Board of Health members, so always great to see you all in the community. And then our team members are also assisting with logistics of the water distribution project, as was previously referenced, and other initiatives which are in process, which we don't have updates on right now, but I'm happy to, we'll be providing more updates at next month's meeting. Thank you.
Oh, that was quick. Wow. Thank you. Next, we'll move to number 14 with the governor's proclamation and Commissioner McKinney.
Yes, so just a couple weeks ago, Governor Inslee worked to extend certain proclamations, and this particular proclamation extends the requirement that anyone who's employed by the state or contracts with the state is still required to be vaccinated. Also, interesting to note that if you are considered a worker, if you are volunteering your time. So this is significant for people, especially comes to mind parents and schools. If you are wanting to volunteer your time in the classroom for your child, even if it's at a private school, this proclamation covers you as a worker. So we still have a situation where I think, unfortunately, that our governor is putting this in place when we've seen that although we have had a lot of information and data that supports that getting the vaccine or either having naturally acquired immunity does provide protection against significant illness and hospitalization, it certainly doesn't prevent you from getting the virus. I think Dr. Barg would have lots to comment on, but we've got folks who, of course, are boosted and double boosted and still getting the COVID virus, which again, gratefully, thankfully to God, it is not something that is, as he has mentioned earlier, resulting in significant illness, especially death. So I would like to see us encourage the governor as a health board to rescind the proclamation. I think we need to go about making this a personal choice if someone wants to get the vaccine, if they want to get boosted, but having this be a public policy, noting that the COVID vaccine unfortunately does not keep people from getting COVID. I think though well-intended, it should no longer be a health policy. So that would be my motion, which is to have this health board write a letter to Governor Jay Inslee, encouraging him to rescind Proclamation 21-14.3.
Motion's been made. Is there a second? You're on mute.
Thank you. I would second the motion.
Been moved and seconded. Any further discussion?
I would like to just comment that I know that, Andrea, I appreciate what you shared earlier. There, are just different ideas and opinions. I don't see, I see that as it happens, it's a reflection of the Board of Health, not necessarily a direct reflection on the excellent work that the Health District does. I want you to know that. I don't discount at all the wonderful work that the Board of Health does, but I also agree that having those vaccines mandated at this time for even volunteers for the state is worth reconsideration.
Well, thank you for that, Councilmember Byers, and certainly the Board of Health has the right to send those directives. Thank you.
Any further discussion or comment?
Yeah, I just have one question. Would the maker of the motion be writing this letter?
Yes, be happy to do that.
And that'll be submitted for approval by the board, I assume. All right, Mr. Ibach, would you take a poll, please?
Yes.
Just a further clarification. Will that letter be an agenda item at our next meeting? That way we can approve the letter?
I think that was the intent, wasn't it, Commissioner McKinney?
I'd be more than happy to provide the draft at the next meeting.
Thank you.
Okay, are we ready to move forward?
Yes.
Okay, so if you're in favor of the motion, please state yes. If not, please state no. Commissioner McKinney,
Yes.
Commissioner Lindy,
Yes.
or Councilmember Byers,
Yes.
Dr. Atterbury,
Yes.
Councilmember Duval,
No.
and Commissioner Anderson.
Yes.
5-1.
Thank you all. All right.
Can I make a suggestion for the board to the extent that this is placed on the agenda? It was listed as Governor's Proclamation 21-14.3, comma, Section 6, which is a fairly specific section. To the extent that this is going to be placed on the next agenda related to a motion to vote on it, could we identify it without the specifics related to Section 6, but overall Governor's Proclamation 21-14.3. I want to make sure that if this board is voting on a decision related to a letter related to the overall proclamation, that there is not any confusion for anyone in the public who wants to either offer comment or be involved on that. That'd be a good way of setting it for the next meeting.
Commissioner McKinney, is that acceptable?
Absolutely.
Council Byers?
Yes. Yes, thank you.
Thank you for that clarification, sir. Appreciate it. All right. Now we'll move on to new business. And we've been talking about this for some time, and I'll kind of give a brief overview. In the very beginning of COVID, we began having daily updates every morning, 5 days a week, on what was going on with COVID and all of the pandemic as it was starting to move forward and grow. That process then moved into a more comprehensive mid-month special meeting in the evenings. And we were able to, I think, accomplish more business that way. But it's come to my thoughts now that we are past that process of having those special meetings. And I think we are, as with today, it's 10:30, and we are just about, well, we're almost through our entire agenda. So I would like to move that we discontinue the monthly special meetings and keep the block time open on our calendars and just discontinue the process of holding a meeting.
I'll second that motion.
Been moved and seconded. Any further discussion?
I would just like to say, it was extra work, but I think it was very worthwhile. I think those of us who have been serving on the board appreciate the work of the staff and arranging all of that, and other board members in the participation of all those extra hours. And I think now that we are past also the process of of appointing new board members and just waiting for an appointment by the, for a Native American representation that the board does not have to work on. I just think it's a timely matter to dismiss emergency sessions.
Any further comments or questions?
I would comment that I think it's unfortunate that we've reached this point, but our state leadership has not. So again, pointing out that we remain under an emergency, according to Governor Jay Inslee. So may he follow in our footsteps soon, would be my hope. But I would offer this. We've just, it's been called to our attention just today that we did previously vote as a board to place some requirements that we not bring forward motions if they're not already on the agenda. If we move towards one meeting a month, that would mean that we would have a significant amount of time that passes before we're able to take action as a board. I would be supportive of this if we saw ourselves going back to allowing ourselves to simply bring forward motions, whether they be on the agenda with specificity or not. That is actually how boards are able to work. If you make a motion, if it fails to garner a second, then it dies. And so if there is something that is outlying that is brought up, it can easily be dismissed by the process that is already in place. What we ended up doing today, which has happened, I think 3 or 4 times, is we've had to then determine something was an emergency just so that we can consider it. I think it's an added step that we don't need. The process is here. So I would be supportive of it if we remove the requirement we placed on ourselves to only be able to take a vote on something if it's already appearing on the agenda.
Any further comments or questions?
Well, I guess
I do have a comment. I just feel like the meeting time is not a friendly time for somebody like myself that works, has another full-time job. What I liked about our special meeting is that it was at an accessible time for me and other people that are working and want to provide input and be participating in our meetings. So I'm sad to see it go, or that we are wanting to remove it. But I also just want to have the opportunity to have a special meeting or even a regular board meeting at a more friendlier time.
Thank you. Commissioner Lindy?
Well, I was going to say that, yeah, I'm okay with this move. I think the idea of still keeping that time slot in place in case there is a need is a good move. Try to keep that on our schedule, and so that if we have something that we feel is time sensitive, that we can convene.
And I would just follow that up to say that the board has that opportunity to call that special meeting within a certain period of time, Ryan. I always get these hours messed up. Is it 72 or 24? How does it go?
It's 24 hours.
So the board, if you hold that time available, obviously you can, within 24 hours, as long as you're presenting to the public. And if we're going to do that, I would suggest the board that we be very specific in terms of what you are identifying is going to happen at those special meetings that get called. That's what got, I know the school district down in Tri-Cities into trouble, was essentially calling a meeting but not being specific about what they're going to be voting on. So my encouragement for the board is, while you hold that time, you can do so within a 24-hour period, but let's be specific about what we are identifying as agenda items, specifically where there is going to be a motion that's going to be called that allows not only the board members, but the public as a whole to be involved in that process.
Thank you. Very good points. Any further comments or questions?
I do have a question. Commissioner McKinney brought up the aspect of removing the necessity of having things be an emergency for immediate action. Is this going to be an addendum added to the motion, or how do we process that? Mr. Elliott, maybe you can help.
I would suggest you deal with this first one first, which has been I think, I can't remember who made the motion here was this Commissioner Anderson maybe? Yes. Deal with that motion first. It's related, so the discussion makes sense that it was brought up, and then allow Commissioner McKinney, if she wants to make a separate motion after this one has been discussed, closed, voted on, to then make a separate motion related to that, and the board can discuss those issues. So that's how I would do it.
Thank you.
Thank you for that clarification. Any further comments or questions?
I would just comment that I'm supportive of Commissioner Lindy's point, but I think that what we're doing here is considering removing it, but we always retain the ability to call a special meeting. And we could certainly do that, especially if there were urgent pressing matters that were brought up.
Correct. All right, Mr. Ibach, would you take a poll, please?
Yes, I will. If you're in favor of the motion, please state yes. If not, please state no. Commissioner McKinney,
Yes.
Commissioner Lindy,
Yes.
Councilmember Byers,
Yes.
Dr. Atterbury, Dr. Atterbury, you're on mute.
He's on the phone or
Oh,
something.
okay. Okay, we'll go back. Councilmember Duval,
No.
Commissioner Anderson.
Yes.
All right. So we have a 4-1 vote with one abstaining.
Dr. Atterbury, can you hear us? Are you on the phone? We can't really tell.
He can't hear your voice, James. He can't hear us.
He's better for it, promise.
Dr. Atterbury?
Yes, I'm sorry, I was on mute.
Okay.
Did you hear the vote? Did you hear the motion and the vote?
I heard the motion and I was in favor of the vote, so yes to my vote. Apologize.
All right.
I had another call come in simultaneously.
Yeah, we figured that. Thank you.
Okay,
Thanks.
so 5-1 is the vote.
All right. All right, well, thank you. Is there any further business?
Yes, I would move that we remove the requirement to have an agenda item appear on our agenda in order to hold a vote at that meeting.
Is there a second?
I'll second.
Been moved and seconded. Any further questions or comments?
Commissioner Anderson, I'd like to share something, but I'll defer to the board first, please.
Okay. Go ahead.
Thank you. One thing I did want to make sure, and I'd like to get James's perspective, is again that the choices that the board makes in terms of raising motions, again, is legitimate. But when those changes directly affect the direction that the health district takes, one of the things that we had discussed was the issue of transparency, so that the public was aware of it, and certainly staff were aware of it. So I'll ask you for your consideration. I recognize that the process of determining whether something is an emergency is perhaps not the most efficient process, but it does get to the point, which is if you do want to vote on something, you may, but that does allow for transparency. And so that's one of the things that we had discussed many months ago, was the issue of what goes on an agenda so that people are aware of it. I did just want to share that issue.
I know this issue, when it got brought up before, Councilwoman Byers had, at that time, as the mayor, had identified the process that the city used, which I thought was good input for the board related to general meetings. To the extent that this issue is being talked about in general meetings, which is our regularly scheduled once a month meetings, that's one thing. Just want to again caution the board, to the extent that this is going to take place at any special meeting we call, we're running into problems. So just so we're clear, and this may, I don't know that we need an amendment necessarily to this, because I didn't write down the exact language Commissioner McKinney said. My assumption was this was going to be the ability at a regularly scheduled meeting to do this, as opposed to special meetings, which again is the problematic area, that if people are doing things on the fly for those, you're running into a problem. So I offer those things.
Thank you, sir. Any further comments or questions?
Yes. I think that I don't know when information is due for the agenda, but I think it is wise, you know, if we have things we want to bring up and things to talk about, you know, I think we have plenty of time prior to the meeting to request something to be put on the agenda. And I think that may be a part of the process that helps with the transparency. I don't know, when are things due for the agenda? Meetings are on Wednesday. When is the agenda items due?
So the agenda items are due the Friday before the meeting.
Okay. So I am willing to go along with the motion. However, if it's not amended to state that the agenda items should be brought in by Friday, so they can be actually on the agenda for the public to be aware of that, so that we can vote at the meeting, then I would then make a second motion that happens.
Okay.
I'm,
The motion is, would you restate your motion, Commissioner?
my motion was to remove the requirement on this board that an item appear on our agenda in order for us to vote on it at that current meeting. And I would amend that to simply say, based off what Mr. Elliott said, is to insert, Ryan, regular meeting. So that is specific to a regular meeting.
I believe, Ms. Byers, you made the second on that.
Commissioner Byers, did you, or Councilwoman Byers, did you make an amendment to that motion? I'm sorry, I'm not following. You're on mute.
You're on mute. You're on mute.
I cannot get my things to on. Councilwoman Duvall, what I was requesting was, I can't make an amendment because I did not make the motion. However, I was suggesting the amendment be made.
All right. Any further comments or questions?
Yes, I just wanted to point out that there is an appearance of fairness doctrine. And in my opinion, this motion goes against the spirit of that doctrine. So I want to speak against the motion because we want to conduct meetings that are procedurally fair. And, you know, we are making decisions, and I want to make sure that we give the public time for input and let people know what it is that we're going to be discussing. That way we can all be prepared for whatever comes to the board.
Thank you. Any further comments or questions?
Yes, Commissioner Anderson, I do. I just, another point of order, that this was not an agenda item. And so would this be on the agenda for the next board meeting?
Mr. Elliott, I think it would be proper to do that, wouldn't it?
Unless we decided that this was an emergency and we wanted to address it today.
I want to copy and paste videos of myself on this topic, and then you guys can just replay them at any given time.
I think that it is correct that we would either need to declare it an emergency or ask that it be put on the next meeting's agenda.
All right.
I think this is a good example of the normal course of discussion, and I'm going to use this as an example. What did appear was an agenda item that caused a continuance of conversation that is related. So in the support of discontinuing special meetings, I made a point of saying that I'm supportive of it if we consider removing this requirement of ourselves to not take action if we decide to in a regular meeting. And, you know, this is now the second time this has come up in this meeting. I don't know if this is any more prime example of exactly why we've got ourselves in this situation. You can make a motion, no one seconds, or it dies immediately. That's the process. But this is a continuance of conversation that's relevant to something. It's germane to what was on the agenda.
And I would just
still have your hand up.
I would just echo, oh, sorry.
I'm sorry. Go ahead.
Oh, I was saying, I would just echo those comments that it makes it so inefficient to require a period of time to pass to vote on issues that are relevant right now. So I would support getting rid of this secondary step that we've added. It just, it screams against efficiency, and I'm all about efficiency.
Thank you. Any further comments or questions?
I seconded the motion for the sake of discussion because I think there are aspects of this that really do need to be considered by the board. However, I feel that if we drop the need for an emergency, I still think it would be expedient and fair to the public that by the Friday before the meeting, if we have things we know we want to talk about, that we would request to be on the agenda.
I also wanted to point out that the Appearance of Fairness Doctrine does state that participation is challenged in a timely manner, a court can invalidate the decision. So if we do bring about a motion at a meeting and we didn't give the public enough time, it can invalidate our action taken at the meeting.
So Commissioner McKinney, in response to your concern about being able to do this, I would think that if something comes up between Friday and Wednesday, if there's something that actually comes up significant between Friday and Wednesday, that we can then declare at that particular meeting an emergency to bring forth something. Otherwise, I really do think in fairness and transparency, it's good that we have it on the agenda and we can do that up to Friday before the meeting.
Councilwoman Byers, I don't disagree with anything that's been spoken about transparency. I absolutely agree that the public should be given advance notice. What I think is more relevant, which has been proven now twice in this meeting, is that there are germane conversations to items that are on the agenda, and so we're not allowing ourselves the flexibility to take action on things that are related and come from the discussion of items that appear on the agenda. So you might not know at looking at the agenda that you have a question and that you have an action that you want to suggest until the conversation occurs during the meeting. So I think that's what's happened twice today. That's just my comment on it. It's not certainly to subvert processes and transparency. It's to allow for the natural progression of conversation related to things that appear on the agenda.
Mr. Anderson, I was hoping we could recognize Commissioner Lindy's.
Yes.
Thank you.
Commissioner.
Yeah, thank you. I appreciate Councilwoman Byers' tack on this, which is, and I think, yes, there's a case to be made on one hand for, the efficiency of being able to act on things at the moment, but it also seems that, wherever possible, we really ought to have things on the agenda at a time so we know what's coming. I also don't like the idea of just being blindsided, and it's issue by issue. It's going to depend, but there could be things that are brought up at a certain time, and I wouldn't want to make a decision because it's just brought on me in the moment, and it'd be good to have some more research. But of course, we could make that decision at that time as well.
Thank you. Any further comments or questions? Mr. Eibach.
Well, we're gonna need to clean up where we are right now. Just so we're clear, at least by my count, and Ryan, you can tell me if I'm wrong. We had a motion and a second on the original. We went into discussion. Commissioner McKinney made a motion to amend so that this issue would only occur during regular meetings. I did not hear a second on that. So we need to clean up where we are, everybody. So Ryan, correct me if I'm wrong. I didn't hear a second on that, on her amendment to her original motion. So
I'll give a second on the amendment to the original motion.
So I think it would make sense right now, Commissioner McKinney, if you could please, with the idea in mind of amending what the change was. And then obviously we've got then a motion to amend on the floor that the board could then vote whether you want to allow the amendment to occur. Then we'll go back to the original motion and work from there.
All
Would you
right.
like me to restate, or are we good where we're at?
I think it makes sense. Can you restate it, Commissioner? I just think we've bounced around in a couple of different places. I think that'd be helpful for the board to vote on the amendment, then go back to the original and work from there.
So the amended motion would be stated that I had made a motion that this board remove the requirement for an agenda item to appear on the agenda, or excuse me, an item for voting to appear on the agenda for this board to be able to take action on that item in that current meeting at a regular meeting was the amended part.
So the amendment is essentially inserting the word regular meeting as opposed to any meeting. I saw that Councilman Duvall asked for a restatement of the amendment. I believe that would be appropriate now. Everybody understands what the amendment is, changing to regular. So Ryan, call for the vote on that.
So again, point of order, this has not been declared an emergency, so it's not an agenda item, so we would not be able to vote on it. Is that correct?
Yeah.
Okay, so it will be on the agenda for the next meeting.
Okay,
I think to prove a point, I would love to let that happen.
all right, thank you. So what's the next step?
I motion to adjourn.
So before we do that, Commissioner McKinney, I think it makes sense for you to withdraw both of the amendment and the motion that you made and state that on the record. And then this board will then agree that it'll be placed on the next meeting's agenda.
I withdraw my motion with that statement in mind.
I'd like to make a another recommendation. Can you forward your motion to the next meeting instead of withdrawing it, so that it could be
She's withdrawing the motion for a vote today. So
okay.
And so the motion will appear on our next, excuse me, the motion item, the agenda item will appear as a possible board action at the next meeting.
Okay.
It'll be on the agenda for the next meeting.
Yes, if I'm Commissioner McKinney, I believe then you'll have to restate the motion at the next meeting.
Thank you for that. I'd be happy to do it.
Yeah.
And with this great display, I would just like to welcome the 2 new members to the board. And wish you all a very good 4th of July.
I'm sorry, but that was funny. All right, so the motion has been withdrawn and it will be placed on the next agenda at the regular meeting for consideration by the board. All right, any further action? Any further? I think there was a motion by Commissioner McKinney to adjourn.
I will second that.
There's been seconded. Any further discussion?
Happy 4th of July.
Hearing none, all those in favor say aye.
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 Aye. All those opposed? We are adjourned. Thank you all very much. Very lively discussion.
Thank you all. Have a great day.
Thank you.
Here, thanks.